there are many more patient needs than just the PASI 90, PASI 100 endpoint, which surely is important. But there's also the wish, and this is from many thousand patients published in the global report on psoriasis by WHO, disease control, but also sometimes itch plays a role. The need to have a normal everyday life, leisure activities, get rid of pain, many more. You see this. And if we see all this, we clearly come to the conclusion that the right drug for the right patients is a very individualized decision that we have to drive, and we cannot just follow RCT data. That's what we heard already from Matteo, but we also cannot just follow one endpoint saying that just with the PASI 90, PASI 100 outcome, we have a clear solution. It's more, it's beyond this. It requires shared decision making, and it requires to listen to the patient about the things which for him are surely important. So with this, I open the discussion between us again, and maybe Luis is the first who can answer this. Is it also your daily practice that you weigh up between different outcomes the patients find important, and does this drive your decision as well?
Indeed, but the problem with relying too much on subjective or perceptions from on the patient side, as opposed to objective assessment of signs of the disease, is that sometimes the better the patient becomes, the more exacting, or the greater the expectations. And there are some issues which might not depend on our treatment, so it might depend on the system, or on some psychological traits, or even psychiatric comorbidities of our patients. So sometimes, of course, for the patient, the expectation of non-recurrence is important, but we cannot provide this for the time being. Perhaps we might eventually be able to modify the course of the disease, but currently we cannot tell our patients, oh, I can assure you that the disease will not respond. There might be relapses, might be longer with some drugs than with others, depending on the half-life and some other characteristics of the drugs. But again, I'm a bit concerned about this, about the patient benefit index, because also it's the same with the LQI. It's so subject to cultural variations, to depending on the sex, the age, or the occupational status of the patients. There are so many factors that go beyond our practice, our abilities to treat the disease. What's your take, Matteo, in that respect?
Yes, I perfectly agree. We have, of course, to analyze different factors, not only objective, PASI, BSA, and so on. We, of course, have to listen about patients' expectation and symptoms and so on, but we as a clinician must drive the situation, because it will be very dangerous if we just blindly follow patients' reports on each and so on, or impact on quality of life. That is very difficult to objectively determine the impact. So, of course, it's important patients' well-being, but we have a very difficult to do. We have to select the best treatment, just trying to make an equilibrium between objective data, patient expectations, and so evidence from real life. So we have to do personalized medicine and just try to catch at the first time the best drug for the patient, to avoid switch and so on. And so it's not easy to try to have a balance between all these factors.
There are many differences across countries and even among regions, but also in the pattern of health practice. In some countries, nurses are plentiful. In some others, they are a luxury item. In some countries, any dermatologist can prescribe a biologic or whatever, can care for complex patients with psoriasis. In some others, this is restricted to hospitals. So there are so many factors that it's very difficult to provide a generalization in that respect.
Yes. I'm very scared. Just one second, just little phrase. I'm very scared about unnecessary switch, because now we have plenty of drugs. So there might be the tendency to more easily switch the drug, just like 3 months to 3 months. And so we must avoid when it's not necessary, just to try to change the drugs.
I think that we owe the patient an answer to the question if his disease-related symptoms and complaints get better with the treatment. And this goes beyond PASI. It goes into fields like itch. In atopic dermatitis, even more, we know that itch is the central symptom, but can also be in psoriasis. And so all these, even not directly accessible components of the disease should be covered. And I think today we have a really easy life in our decision making, because once we choose the drug which has the highest probability of clearing the skin, many of these other goals also improve. That's what we have seen, not completely, but there is a trend that with the more powerful drug in terms of the clinical outcome, many of the problems are also managed. And this is why my conclusion from this is not to relate to all these single problems the patients focus, but to provide the drug which provides the best expectation of success, and start with the most powerful drug rather than with the weakest. And this is what is my way of doing it, but I'm happy to hear your comments on this.
Oh, patients, we are not seeing them so often, so we must tell them that there might be some fluctuation in signs and symptoms of the disease. And as a matter of fact, I get a bit of, I wouldn't say nervous, but when the patient is completely clear at each appointment, sometimes I think that I would like to adjust the dosing so that there's a bit of inflammation that I know I'm treating. Because otherwise, I'm not concerned about over-treating, but I like to have something which is the basis, the inflammatory basis of psoriasis that I want to be able to treat. And this is something that there might be some differences of opinion and of practice in that respect. I don't know how do you approach that, but perhaps it's a bit of attention deficit disorder, but when a patient comes completely clear, I get a bit nervous.
Yeah. Yes,
No,
I also.
I think, first of all, I'm happy when the patient comes and is cleared. But the question then comes: do we have to modify? Can we taper? Can we play with the dosage and intervals? Of course, because we do not want to overtreat him. And as you say, if there's no sign at all, then the treatment may be not needed at this in this dosage, for example. Yeah. On the other hand, maybe Matteo, you can also comment on this in terms of comorbidity. We are not only treating the skin, but also the chronic systemic inflammation. And if we don't see anything, it doesn't mean that there's existing inflammation in the system. This is why I also emphasize long-term treatment if patients have the disease, severe disease for a long time.